Welcome to the Currents of Public Health webinar series presented by the School of Public Health at Georgia State University. My name is Brian Greer and I'm the Senior Director of Development for the School of Public Health. The goal of this series is to explore relevant public health topics with members of our community. Today's topic is bringing Alzheimer's disease and precision medicine to public health. Our guest is Professor Jalayne Arias, who is an Associate Professor at the School of Public Health at Georgia State. Professor Arias is a multidisciplinary researcher and scholar leading studies at the intersection of science, healthcare, policy, and law. Her research portfolio addresses critical policy, social, legal, and ethical challenges for older adults in neurosciences. Her prior and ongoing studies have identified employment and insurance discrimination based on emerging techniques to identify risk for Alzheimer's disease, evaluated genetic data sharing guidelines and research, consider the relevance of return of research results for recruitment and enrollment, analyze private payers' coverage policies for genetic testing, examine challenges to financing long-term healthcare, identified policy needs within the criminal justice system and managing and caring for older adults, and characterize financial and legal decision-making in young onset dementias. Her research has been funded by the National Institutes of Health, including an NIH Career Development Award. She has also received funding through foundation grants and nonprofits, including the Alzheimer's Association, the Marcus Family Foundation, and the Hellman Family Foundation, and the Aging Research and Criminal Health Network. Today's webinar will be guided by three general questions. What are you doing? Why is it important? And how can we get involved? Quick note, if you have a question at any point during our conversation, please feel free to type it into the Q&A box and we will try our best to answer. So let's begin. Professor Arias, welcome to the webinar. Please tell us about your research and why it's important.
Thank you so much, Brian, for the invitation and for including me as part of this series. Today, I'm really excited to be able to share my passion and excitement for Alzheimer's disease and related dementias as I see it a public health priority. What I'm hoping to do is to demonstrate to this audience why examining these issues in Alzheimer's disease is a fantastic way to think about public health and precision medicine topics. I'm going to provide 4 issues as highlighted examples, and then I'll talk about how I'm going to plan to build this research at GSU. So let's just start with some foundations. Alzheimer's disease and related dementias has had historically some critical public health challenges. Typically, the focus has really been on the caring lens of Alzheimer's disease and related dementias, really focusing on issues related to symptom management, caregiver burden, safety, and long-term care services. And there's valid reason why this has been a traditional focus of public health in the ADRD spectrum. First of all, we know that caregivers do in fact experience significant burden. I, in my own data, have found multiple reports of caregivers indicating the sense of being overwhelmed and having a difficult time managing their current obligations at work with childcare and whatnot, as well as still serving as a caregiver for their loved one. We also know that caregiving is a risk factor for mortality and morbidity. But yet there's this lingering thing that's existed for a long time. The data around Alzheimer's disease and related dementia demonstrates that individuals are often underdiagnosed, misdiagnosed, or the diagnosis is just frankly missed. In my data, I have found reports of caregivers sharing their frustrations as they would take their family member to be examined and be turned away or find that it was often a struggle. I hear stories time and time again of caregivers reporting their sort of journey just to get a diagnosis. Often symptoms are disregarded, they're given unclear responses, they are treated for another condition, or they misdiagnose the type of dementia that is causing their symptoms. However, a shift in Alzheimer's disease and how it is defined and diagnosed has really revolutionized the field. This includes offering a new potential for preclinical risk assessment. Traditionally and historically, Alzheimer's disease has been diagnosed and defined by its clinical symptoms alone. However, in the last 2 decades, we've seen the emergence of biomarkers through imaging and now blood-based biomarkers, which allow clinicians to not only more accurately diagnose Alzheimer's disease, but also to identify it earlier. And there is a potential that this allows us to identify risk for the development of the symptoms at a preclinical stage up to 20 years before somebody begins to experience symptoms. This creates a new shift in Alzheimer's disease research and a shift in public health consideration. It now allows us to prioritize these other two areas, preventing and treating, as a public health interest. It allows us to think about more in depth the modifiable risk factors and predictive testing. In the context of treating, it helps us think about diagnosis. And then now we are starting to see the emergence of disease modifying therapies. So how do we think about some critical public health challenges through the lens of Alzheimer's disease? Number one, much like other chronic illnesses, Alzheimer's disease is faced with discrimination. In my work, I study discrimination both in the context of employment as well as in insurance. Today, I'm going to briefly just highlight the employment component. We know that adults are working past the age of 65. And in fact, we know that there can be benefits for adults working longer and later in life. However, what this means is that adults are now more likely to experience age-related chronic conditions while they're working. And this could include Alzheimer's disease or other kinds of cognitive impairment. So we've begun to think about, well, if somebody had a preclinical risk for Alzheimer's disease, how could that information be used by their employer? And are there policy changes that we need in order to better protect individuals? In my data, dementia experts have told me that they are in fact concerned about the use of preclinical biomarkers by employers. Here, an expert saying, and it would, the downside of the potential for a preclinical biomarker would be if it got into the wrong hands, if it was used to do her harm in terms of employment or insuranceability. There are certainly laws in place to prevent those things from happening. So we, in fact, looked at the laws. In 2014, when I was early in my process of examining this issue, we looked at the three significant federal laws to determine whether any of them might actually provide protection for individuals who are at risk of Alzheimer's disease based off of preclinical biomarkers. Note that we looked at the Americans with Disability Act, the Affordable Care Act, and the Genetic Information on Discrimination Act. It's important to note that there's a difference between genetic information and preclinical biomarkers. While both important, GINA would not protect individuals who are found to be at risk of Alzheimer's disease based off of amyloid or other preclinical biomarkers. We also know that as individuals begin to develop symptoms in their workplace, that there's some subtle evidence of unfair treatment. We got this report from a family member whose wife was a teacher, began to experience symptoms, and the employer put this individual through a series of different evaluations. And the assumption ultimately was that she was failing as a teacher, not that there was a potential other cause to her declining performance. However, we can't think about policies in this realm without thinking about issues of public safety and safety-sensitive industries. Here we have a family member describing some of the issues that could emerge or emerge for their family when her husband, an engineer, began to experience symptoms. And the decision-making process they went through and determining whether and when he should inform his partners about the potential issues, and also how to adjust his work so that he could continue to be active, but not put others at risk. We've explored this in some other areas as well. So we've looked at whether or not the FAA should evaluate or use preclinical biomarkers in the context of pilot screenings for those who are still asymptomatic. And we've also examined questions around the legal and policy challenging to addressing cognitive impairment in federal officials broadly. The second issue I want to highlight to you is dementia within the prison and criminal justice system. We are currently looking to understand how criminal justice system manages individuals with dementia. We are just now starting this really exciting work to better understand what happens when an older adult is arrested with symptoms of dementia following a crime. We've conducted 15 semi-structured interviews with prosecutors and defense attorneys to identify their experiences with dementia and or potential challenges post-arrest. We are also in the middle of conducting an empirical analysis of some legal trends that we see. We're hoping to be able to systematically map standards for post-arrest trial and sentencing at the legal context. What are some of our early takeaways in this realm? Well, we've identified that there's a lack of systematic screening process for dementia post-arrest. Talking to attorneys, we've heard time and time again these stories of an individual being identified as having dementia only out of mere chance, not out of anything that was done systematically. They also just describe significant challenges in where to place an individual with dementia post-arrest. It is often not appropriate for them to be within the jail system. However, in some situations, it may also not be appropriate for them to be housed within a psychiatric facility, which is the most likely the route that they would go. Additionally, we hear time and time again attorneys describing their lack of training on dementia to be able to understand how the disease could impact decision-making and how to integrate it into the legal system. We have found that the two legal mechanisms available to divert an individual who has dementia miss the mark given their focus on psychiatric populations, including competency hearings and the plea of not guilty by reason of insanity. Issue number 3 that I'd like to highlight: cost, payer coverage, and access. This has become a highlighted issue as aducanumab was approved by the FDA, and cost has started to emerge as an ongoing conversation. I've been working with health economists to explore some really interesting questions around private payer coverage policies for genetic testing, as well as identifying the need for an economic and policy research agenda for biomarkers of neurodegenerative illnesses. What we have found through our work is that payers are not yet ready to either provide coverage for tests, either genetic or other blood-based biomarkers, but that as the field shifts, that we're going to need to reconsider some of the policies in this realm. And this is particularly important when you look at the costs associated with Alzheimer's disease. For example, working with a health economist at Cornell University, we have identified that individuals who have Alzheimer's disease, or specifically dementia, have higher out-of-pocket payment costs in both residential care and nursing home care compared to their counterparts without dementia. It's really important to understand that these costs are being paid by families directly or self-paid by the patient themselves. And particularly when we looked at the amount that this cost took up of their income, that it was taking up a significant portion. And the final and fourth issue that I will highlight in the speed race through some of the most perplexing issues that I think exist right now is the role of data sharing. Data sharing refers to the practice of sharing data collected by one investigator with an investigator at a second institution. It is used to be able to maximize the value of the data by creating larger data sets that can better identify and be more diverse. And when you talk to investigators, they admit up front that it's paramount, that the key to unlocking some of the most challenging questions in Alzheimer's disease and related dementias is the sharing of data amongst investigators. However, they also acknowledge that the system is not currently perfect. We've heard from investigators that there's challenges related to how data is being used, in part because investigators are unaware if their counterpart at the new institution are going to use it appropriately. The issues around embargoes and incentives are investigators often state that they put all the work into cleaning the data, QCing it, meaning quality checking it and processing it, and then releasing the data, and other investigators are at the same stage of the analysis as they are. This is particularly important in a context of an academic environment that highlights the need and the importance of publication. And then lastly, data withholding. We've heard multiple stories of investigators withholding data, usually using some ethical rationale, often arguing things like maybe the participants did not consent to their information being shared. So as means of a sneak peek, we currently have a grant under review to look at these practices within Alzheimer's disease specific as a field, or Alzheimer's disease research as a field specifically. The goal of this grant would be able to identify the factors that predict how ADRD investigators manage incentives and disincentives for sharing data within the context of federal policies, in order to promote data sharing both in the frequency and the quality, to look at some inequities that we believe exist in the system, and to support therapeutic discovery by maximizing the use of collected data. There's a lot in progress right now that's happening at my lab. That's currently a one-person shop, but we're really excited to be able to building it, and I'm very excited to be able to build this at GSU. I really believe that precision medicine is driving research towards reducing disease burden, and this is a huge public health benefit. And a program at the intersection of precision medicine and public health and aging would be able to harness interdisciplinary work and focus on early detection and risk factors. It's really important that we consider not just the public health issues, but how this integrates with policy, ethics, and law, as well as the clinical field itself. Illnesses like Alzheimer's disease and other related dementias serve as a major opportunity to examine some of these really perplexing public health and policy challenges and offers huge opportunities for collaboration across populations. I must acknowledge that I do not do this work on my own. While I am currently at GSU in a lab of one, I've had several incredible collaborators and mentors, as well as a prior research team that really helped me complete all of this research. And to that, I will just say thank you. And I'm really looking forward to questions, comments. Brian, if it's okay with you, I'll stop sharing screen.
Yeah, that's fine. Well, thank you very much for that presentation. I have a few follow-up questions. My first one is, so what do you see as the biggest threat facing individuals with Alzheimer's disease and dementia?
Sure. So I describe my research as translational process. I think Brian, you and I talked about this, is that I look at the issues that affect patients once they leave the clinical office with either a diagnosis or a risk prediction. And I think, quite frankly, there's a lot of things outside of the clinical office that are challenging for patients, but I think one of the biggest challenges is, one, our long-term care system is not quite ready yet for all of this, or is it equipped to really be able to support this. Long-term care is just really not well financed right now in the United States. And that's something that definitely needs to be addressed so that we can provide better care to patients and their families. It's really inequitable, honestly, because those who get access to high quality care are those that can afford to pay for it out of pocket or happen to maybe have private insurance. But some of my other research demonstrates that the private insurance industry is really not an available option for most.
A follow-up to that, is there, it sounds like there's not really things in place to protect sometimes some of these individuals with private insurers. I mean, are they protected, I guess, in pre-existing conditions or anything like that with the ADA or ACA, I should say?
Yeah, so long-term care insurance, private long-term care insurance is not covered within the Affordable Care Act. And it's one of the two areas of insurance, we think potentially even three. Life insurance is similar, where individuals' health information can be used against them in the decision-making process as to whether or not an insurer will or will not offer a policy, and then setting the premiums. And so it's actually about 24% of adults are denied long-term care insurance based off of health information. And so if somebody were to have a pre-existing condition like an Alzheimer's disease diagnosis or the risk for developing Alzheimer's disease, it is highly likely that they would be either denied or the premiums would be so cost prohibitive that it wouldn't be a true option. We've actually even heard in our data, speaking to caregivers of individuals with Alzheimer's disease, that the mere mentioning of a concern around a memory was enough for an individual to be denied long-term care insurance.
How is that? So my next question is, I'm hoping to kind of contextualize some of the research that you're doing, and I'm just curious, are there states that are doing a really good job at caring for individuals with dementia? And if so, what are some of the lessons that we can learn here in Georgia from them?
I don't know if states are. There's definitely people that are doing a really phenomenal job. Researchers have really been pushing forward research to how to improve the quality of care, particularly in the gerontological field. I will say that we need more research to better understand how states differ and how their policies are actually affecting the quality of care. This requires something as massive as a 50-state survey on different issues and topics that would be relevant. I do know that Washington State recently passed a law that is now being implemented to provide a public option for long-term care insurance or for long-term care coverage. And so how that folds out will be really important to see if that really improves the quality of care. But I think that this is an area that we definitely need additional research.
So in your opinion, what does the future of home care look like for families caring for loved ones with dementia?
I'm sorry, can you restate that again? I got distracted by the question in the chat.
Sorry, and we'll get to that chat. So I said, in your opinion, what does the future of home care look like for families caring for loved ones with dementia?
Yeah, so I think one of the big things that we need to focus on is trying to figure out how do we provide more individuals with access to in-home care. Most people say that if they are receiving care, they'd like to receive it at home. Yet, because Medicaid is the largest payer of long-term care, that's who we rely on. And each Medicaid system is different depending on the state that you're in. And different states have different availability of access to community-based care, either difference in the number of Medicaid receiving families that can access community-based care or the type of care that's being received. And so I think that there's some really interesting and innovative things that are being done in the research, but until we find a better way to pay for it, it's going to be limited in our ability to implement that.
So what advice would you give to individuals and families following an Alzheimer's disease or dementia diagnosis?
Sure. So I think it depends on where the family is at in the diagnostic process. So of course, there's time to grieve, and you want to be sure that you kind of take that time to process. If the individual themselves is still early in the disease process, this is the time to have the conversations that most people don't want to discuss. So this is the time to talk about what their wishes are and what their values are, what kind of care they'd like to receive and where to receive it at, and also to have an open conversation about what is that threshold for the family in which they can no longer provide care for themselves. And for every family, that's going to be a little bit different. But I've heard these stories. I see it time and time again where the conversations aren't had, and then the family really struggles with, getting to that threshold and not knowing how to make the decision. It's also a really good time if you have the resources to be able to seek out an elder law attorney and or financial planning to make sure that you have a plan in place for how you would be able to bring in that extra care.
I think we both saw the question in the chat. So what it says is, from what I've read, there is hope that early detection of dementia could lead to better overall outcomes, but there is not a strong body of evidence that it had helped at this time. Are there any studies in place to see if there are any concrete benefits?
Sure. So, there's a lot of studies right now that are really focusing to try to understand, one, how we validate these biomarkers to assure that they are measuring what they need to be measuring in order to be predictive. But there are studies that are also looking at sort of what are the outcomes from integrating them within the symptomatic population. The IDEAS study that was initially developed out of UCSF and led by Gil Rabanovich has looked at how amyloid imaging affects different clinical outcomes. And so I can refer you to that. It's a really fantastic study. There's other studies like REVEAL that are looking at sort of how patients and families deal or manage once they learn that they're at risk for Alzheimer's disease, either through genetic information or through amyloid. And I think that these are the kinds of studies that need to continue to go on, is just really better understand, once a patient gets that information, what do they do with it and how does it help the decision-making process? But I think we're still really early in understanding how this information will be used clinically.
So my third main question here is, so how can we become more involved in your research, and are there any resources you would recommend?
Sure. So, Brian, you and I talked about this yesterday. Like, the biggest thing right now is just human capital. Like, I'm very eager to collaborate, and I think some of the most powerful things that we've been able to accomplish, with the people that I've been working with and who've worked with me as research coordinators and whatnot, is the success from collaborations. So, for example, the economic studies that I referenced really comes from the opportunity for me to work with economists who found this area interesting and important. And so I think that that's, I'm always open to collaboration. I'm always open to students wanting to work with me. And I'll be slowly building out a lab as I get funding to do so, and just really bringing people in to help be able to be more efficient at getting data out into the world and being able to collect more data. As far as resources, I always reference people to the Alzheimer's Association. They've done a really fantastic job collecting this information. Also, the National Institute of Aging has a really wonderful page that describes different aspects of dementia, as well as AFTD, which studies the frontal lobe dementia, which is the second leading cause of dementia.
And so I guess I have just one more kind of follow up to that is, you've talked a little bit about why you are coming to Atlanta and, as a relatively new faculty member. I don't know if you want to speak some to that, of what was your decision making coming here, especially with your interest, and what benefits you see by being at Georgia State.
Yeah, there was a lot of reasons I was super excited to be able to come to Georgia State and specifically come to the School of Public Health. Atlanta drew me in because it is such a collaborative city. I'm really excited for the opportunity to be able to work with Emory as well as Georgia Tech and build out those collaborations. I think the energy, but more, and like this was a major driver for me, the energy at GSU around innovation is just huge right now. There's really fantastic initiatives with a new president and our new dean at the School of Public Health to really make GSU a leader in in all areas. And so that kind of energy is something that I grab onto. I'm really passionate about my work, but I like to do things differently. I like to think outside the box. I like to think interdisciplinary. I like to work with people who aren't like me. And then GSU just felt like the perfect home for that. And I think also being seated in Atlanta really offers a diversity of our student population, as well as just working within a Southern state offers huge opportunities to have impact in a way that I don't know that my work has had in the past.
So my final question is, if you could change anything concerning health policy for caregivers and individuals with dementia, what policies would you implement?
Yeah, I think there's two realms. One is I am really convinced that we need to figure out the employment discrimination issue. Speaking with other researchers in chronic illnesses, Alzheimer's disease is not the only one that's facing this question. And the policies are really tricky because it's not just a clear, oh, you can't discriminate against this person question. We really have to think about it at a full picture. Apologize, perfect time to get a tickle in my throat. And then the second one is that we need better policies around long-term care financing. And I know that this administration has really taken that seriously, and there's things moving at the federal level, but I think we need to really make sure that the policies that come out to better finance long-term care are really moved forward in the right way.
Excellent. Well, I want to thank you for attending the Currents of Public Health webinar today, and I want to thank Professor Arias for her informative presentation. Please save the date for our next webinar on Thursday, March 31st at 12 p.m. So that's next week, featuring a School of Public Health alumni panel who will be discussing the role of public health in healthcare systems. In closing, the School of Public Health at Georgia State University is one of the most diverse schools of public health in the nation, offering a Bachelor of Science in Public Health, a graduate certificate, a Master of Public Health degree in 6 concentrations, a PhD degree in 4 public health areas of knowledge, and a Doctor of Public Health. The faculty and students conduct research on complex public health challenges facing cities across the globe. Our work is often carried out in partnership with communities, the residents, and community-based organizations committed to health equity. If you'd like more information about our programs or how to support the work of the school and our students, please visit publichealth.gsu.edu. Also, check out our alumni page at publichealth.gsu.edu/alumni. Thank you again to Professor Arias, and thank you for attending. And please join us for our next webinar. Have a good day.